This is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium. And I'm very pleased today to be talking to Alan Chip Teel. He's a family physician. He is a graduate of Lancaster General Family Medicine Residency Program. He's currently up in Damariscotta, Maine, a lovely little coastal town in Maine. He's been there for many years. He was the creator of something called Full Circle America, and really focused on keeping frail elderly people at home. And one of the things, Chip, that's always impressed me about you is early on you told me that you considered somebody ending up in a nursing home as a failure, and that you did all you could to keep people empowered so they could stay in their own home. He's now focused on Alzheimer's and its role in geriatric health. He's moved from a family physician who was pretty much full scope in his work, in his practice, and now he's developed a heavy focus on geriatrics. And as I said, keeping people in their home is a main consideration. And I think what he's about to talk about is something that is within the scope of any family physician who shares that passion to help particularly frail elders as they're coping with dementia and Alzheimer's so that they can stay at home. Chip, thank you so much for joining with us today.
Well, thank you, Larry. This has been a natural progression for me from a full service family physician to focusing on one aspect of helping people stay in their homes, in their community. And it is not meant to minimize all of the enjoyment that I've had for everything from delivering babies to doing hospital medicine. But I think the work that I'm doing now needs to be talked about a great deal more. And being a family doctor in the oldest county per capita, in the oldest state per capita in the country, it kind of makes sense that I ought to be doing some geriatrics. And what I was doing was focusing just on a geriatric practice in the last few years. And then my little primary care office, I moved it into the basement of an assisted living home that I had started about 25 years ago. And my primary care office was there. And I started rubbing shoulders much more frequently with the residents of the assisted living home in their day-to-day life. And it really started to show me, even in something that I consider a high quality, home-like assisted living facility, how relatively limited the day-to-day life was of the elders that were in these homes. And so that got me thinking about something that I've since borrowed, called successful aging. And what would that be about? And like many people, everything from food to exercise to purposeful living, is got to give you some reason to get up in the morning. And that led me to think about how to enrich the lives of these folks that were living in this assisted living home. And one thing led to another, and after doing a very modest successful aging program, which focused an awful lot more on the role of diet, exercise, and purpose in improving someone's quality of life, I got enamored with how much research there was out there about how these things actually could improve your brain. And even though as a family doc, and as all of us who do lots of good history taking, we realize that all of the things that we've been doing to control diabetes, blood pressure, cholesterol, heart disease, should also be making a difference in our cognitive function. But like most practitioners of any stripe, there is a general lack of knowledge that the brain is plastic, that neuroplasticity is really very, very likely to be done if we maximize the things that you need to improve your cognitive health. Um, and that was a real surprise to me because I thought I was keeping up on things. And it led me to the people that have written about and started to put into practice how you can reverse cognitive decline. And at that point, I became very, very enamored with the work of Dr. Dale Bredesen at UCLA and an aging center on the West Coast. And I wanted to try to replicate some of his work in our community on the coast of Maine, on the East Coast of the United States. And I was doing a part-time work at a small health center a couple of towns over from me, just on weekends. And I recruited, with their help, about 25 people to start a pilot group with me to focus on reversing cognitive decline. And very frankly, we're in our middle of our second year of that program. And in year one, I was a real rookie. I was really very, very limited in what I could do to try to implement this successful aging program a la Bredesen, and adding to it my own flavor and my own interest in certain aspects of the program. But Bredesen wrote a book called The End of Alzheimer's Disease that came out a couple years ago. And some family physicians have read about him and even tried to implement a lot of his work in their own clinic. I took it a step further, and after I found a reference article from the Journal of Alzheimer's and Parkinson's Disease that reported on his first 100 patients who had anecdotally all improved their cognitive function with this program, I said, this isn't pie in the sky. This is something that I would like to see if we can do this. And I too was very, very skeptical because of my lifetime of practice, where putting people on a little Aricept or Namenda or both of them, or maybe an Exelon patch, and trying to hopefully find a few people with a B12 deficiency or a thyroid condition that might be a contributor to their Alzheimer's disease. The idea of somebody actually being able to tout that there was something really profound that you could do for Alzheimer's disease that often succeeded when all of us have been taught that there really isn't anything to do with Alzheimer's disease was game-changing news for me. Again, being skeptical, I told all the individuals at the beginning of all of this work that I wasn't a researcher, that I wasn't a geriatrician, but I'd done an awful lot of work in family medicine with older individuals and had a special interest in trying to help older individuals stay at home, as Larry had alluded to with Full Circle America and my assisted living homework and all of that. It really was very exciting, and little by little over year one, I started to get very, very hooked on what we could be doing here. And then by the end of the year, I was starting to see some results. And by results, they were small victories. A 90-year-old man who went from having forgotten how to dress himself to starting to dress himself again. A retired chemistry professor who was now counting on his fingers because that's all he could do anymore. And within a year on this program, he was doing the highest level of Sudoku, and he was playing cribbage with his wife in the evening and doing all of his counting and pointing on his cribbage board in his head. And other folks were stopping their decline. Nearly everybody in the program remarked that they were not losing ground. And there were a few of these other successes, people that were no longer misplacing things like they were before, people that were having an easier time remembering people's names, or the name of something came to them more easily. So how do you objectify this? How do you describe it? And that's what I hope to do in the next few minutes, if that's what you think would be most helpful, Larry.
I think it would be very helpful. I'm very interested, Chip, uh, with what you call the program. What were you doing for these folks uh, to help produce these kinds of results?
Sure. Well, the surprise is that there are not any parts of this program that anybody can't implement, but it is not easy. It's a lot of lifestyle change. And as somebody who's worked a whole lot relatively unsuccessfully to get people to change their diet or change their exercise routine or do all of the things that it takes to live a healthy life, I really believe we need to fundamentally change our ability to do the uh, interviewing skills and the motivational interviewing and all of the things that it takes to bring this to a large population. The basics are healthy eating, exercise, and when we eat. Um, and the healthy eating is, sometimes people describe it as a Mediterranean diet, sometimes people describe it as a ketogenic diet, sometimes people talk about it as an Atkins diet. Over my career, there are a lot of ways that this gets described, but essentially it's lower carb, healthy fats, less processed food, more fruits and veggies, and making your portions of meat be a little bit smaller, making your wheat intake be a little bit less, using some supplements. Um, uh, and one of the other things about it is when you eat, you want to get your body used to burning fat rather than carb, because actually one of the tenets of this view of Alzheimer's disease is the same way that we talk about insulin resistance on a body-wide basis for so many of us with a metabolic syndrome. The inference is that there is actually an insulin resistance in the brain that makes it less able to use the energy of glucose. And we really want to we want to move from just burning carb to being able to burn fat effectively to grow new brain cells. The exercise piece is anything that will get your heart rate going and make you breathe a little bit harder. And you need to be doing this 3, 4, 5 times a week, ideally for 30 to 45 minutes, like heart healthy recommendations are. But you can start out at 15 or 20 minutes or even 10 minutes to get there. The time that you eat is valuable because, and important to this program, because you need to eat supper a little bit earlier and breakfast a little bit later to have 12 or 13 or 14 hours between the end of your supper and the beginning of your breakfast. And if you do that, your body is learning to burn fat. And the better your brain is a lot of fat. So a lot of these things are how do we optimize everything that we do every day for brain health. And a lot of the research that has been done all over the country uh, shows that a healthy diet is also an anti-inflammatory diet, and a healthy amount of exercise also helps you build new brain cells. And for all of the skeptics out there, like me, starting out with this, I didn't believe that you could just do a couple things like this and make a substantial difference in brain health. But behind me on my desk here, I have hundreds of articles that are really just the ones that I picked that really help tell this story from researchers all over the world who have shown that these kinds of things individually make a difference on cognitive function and reduce your risk of dementia. And what Bredesen and his gang have done have put all of this stuff together so that you focus on everything from diet and exercise to sleep to reducing stress and anxiety and depression and taking appropriate supplements, minimizing toxins, minimizing head trauma, all of these kinds of things, focusing on improving cardiovascular health, because if it's good for your heart, it's also good for your brain and all of the vasculature that's in your brain. So these things all can go together and produce a cumulative effect that is more than the sum of its parts. And again, it's all about trying to optimize brain health. And there is a very big dose of diagnostics that is done here too. So the laboratory evaluation was some of the biggest areas of improvement that I needed to understand. Uh, uh, there is a marker called a apolipoprotein E that is increases my risk of Alzheimer's disease if I have this or not. And it is a marker that can be done in any lab. Frankly, they're doing it on 23andMe and all of these other things that you can do with your own spit test on your own. And the background for Alzheimer's disease is that the rate in the population as a whole is about 10%. But if I have one of these, rate is 10% after age 65. And if I have one copy from one of my parents, my rate is 25%. And if I have two copies of this ApoE, one from each parent, my lifetime risk of Alzheimer's disease after age 65 goes up to 50%. So again, not 100% at all. So no reason to, for physician-assisted suicide or something like that if you have one of these markers, but at least a reason to get serious about this. And Bredesen suggests the same way that we should recommend a colonoscopy at age 50, we should recommend a cognoscopy or an evaluation of what our cognitive risk is of having memory impairment as we get older at age 50. So in addition to this genetic markers that are readily available, you look for markers of inflammation, like a highly sensitive CRP or a homocysteine level. You try to measure places where my hormones and vitamins are deficient. And that might be things that we're commonly thinking of, like vitamin B12 and vitamin D levels. But it also might mean looking at thyroid, adrenaline, estrogen, testosterone, a variety of other hormones that we're used to measuring. But Bredesen takes it to another level by saying we shouldn't just measure these things, we should try to correct them to the optimum level for brain health. And the optimum level for brain health might be different than the lab normal that we've all gotten used to treating. For instance, with a B12 level, I've always been surprised, as I'm sure many of your listeners have, that the range of normal for B12 is from 200 to 900 or 200 to 1,000. And so if you're at 300 or 400, you're technically normal. But Bredesen says we really, for brain health, you're going to grow new brain cells better if your level is 500 or 600 or higher. And on with vitamin D levels. The labs say vitamin D levels are good if they're higher than 25. Bredesen says they ought to be higher than 50 in order to maximize new brain cells and to give them the nourishment that they need. The other way that was revolutionary for me was to look at something called a volumetric MRI. A volumetric MRI is where you do a regular MRI scan of your brain, but in addition, they do a couple of extra sequences that takes about another 10 seconds. And they add to it a computerized app that volumizes every single subsection of your brain. And by looking at the subsections of your brain, you turn a very limited MRI report into something that is a game changer. And that's what I'd like to show you next. I'm going to share my screen. Hang in with me for a second. Can you see that, Larry?
Yes, I can see it.
So this is one of the patients in the group that gave me permission to put their results up on the board here. What I usually get is this paragraph in the middle, and it just says something relatively nondescript, that there is periventricular and deep white matter changes that is, quote, a stable finding. And then it says the 4 words at the bottom, mild atrophy is present. This is so common that this is all we get. Or it says mild atrophy that is age related is found. I can't do much for that except say no stroke, no tumor, no bleed. Now, when I do a volumetric MRI, rather than that, I get the following. This is what I get instead. I get 80 sections of your brain that have been measured out in cubic millimeters and compared to age and gender match controls. And with this, I could do a lot. Now, no practitioner does much with this, including neurologists in general, internists, family docs, neuroradiologists. They don't ask for this, they don't know about it, and they don't, if they do know about it, don't get it because, as several of them have shared with me, they don't know what to do with the information. And I would acknowledge that I didn't know what to do with this information either. And Bredesen and his group look at a couple of parts of this only. They look at how much gray matter I have. And if you look at the gray and white matter total in the top left, where my cursor is moving, you would see that this guy's gray matter is pretty darn sharp. He is in the 87th percentile for people that are the same age, which happens to be 85 years old. But if you look at some other parts of the brain, you can see that he has some components that are down in the 13th percentile, the 12th percentile, over here, 5th and 7th percentile. And Bredesen, even in his group, don't really pay much attention to all of these other subsections. So I started looking at what do these other sections do and what can they tell me about the patient. So that brings me to the next part of my presentation, which is something that I call functional neuroanatomy. And this is where I had to educate myself about it, because now that I had 80 measurements of 40 sections of the brain, left and right hemisphere, what do they do? And so I went through all of the research that I could find online to make something that I call my cheat sheet or guide to the volumetric MRI. Even the company that created the volumetric MRI doesn't have anything like this. So it required me spending, I don't know, 40, 60, 80 hours researching what was known about these different parts of the brain. And what it did for me was be able to talk to patients in very profoundly different ways. This is for, I want to give you a couple of examples. In the superior frontal lobe of the brain, which the frontal lobe of the brain we think of as being the management center for executive function. And many of us have learned that and can tell people that when they have a frontal lobe stroke. But the superior frontal lobe of the brain has to do with my ability to handle a checkbook or do a complex task like following a new recipe or assembling a kit of something for my grandkids. And then the middle frontal lobe, which is a separate section, has to do with my ability to pay proper attention in order to form something. And then there are other parts of the brain in the frontal lobe that have to do with writing function. And all of these parts of the frontal lobe of the brain end up being an important part of converting short-term memory into long-term memory while I'm asleep. Then in the temporal lobe of my brain, where this guy had a few deficits, there are many parts that contribute to language comprehension. And some of them, many of them are going to be subclinical until I get down to a certain level of dysfunction. But even things like the fusiform part of the brain, when it is enlarged, is when certain people have gotten very good at learning precise things in their everyday life. People that are chess experts or car experts have a exceptionally large fusiform part of their temporal lobe. And then people that have Alzheimer's disease, our topic today, is that the entorhinal cortex is the first part of the brain that is atrophied when people progress from mild cognitive impairment to Alzheimer's disease. Lastly, for today's purposes, the hippocampus here is very, very important in forming new memories, but it can be damaged when I have transient global amnesia. And it also has to coordinate with other parts of the brain when I want to figure out what I'm looking at. Let me give you one more example, if I may. When I look at Larry, my eyes need to send a signal to my thalamus, and my thalamus has to relay that information to my occipital lobe to start to process what I'm seeing. And then it sends it to a part of my parietal lobe for further processing. And then the parietal lobe sends it to my temporal lobe to say, have I seen that face before? Should I recognize that expression? Can I understand that expression? Should I be afraid of that expression? And if that's a new piece of information for me, then it will send it to a part of my frontal lobe to store it until I go to sleep tonight. And then the storage part of the frontal lobe of my brain will send it from that thumb drive up to permanent storage in my hard drive somewhere in one of the association areas of my parietal or occipital lobes. So there are a whole lot of steps that everything has to go through, and the brain coordinates all of these things almost seamlessly and almost instantaneously. But you can see that if there are 7 or 8 or 9 parts of the brain that all share the processing of one thing, that it would take quite a bit of damage to a lot of areas for me to not be able to uh, function at all. And so we have quite a bit of cognitive reserve. And with that cognitive reserve, we are able to make a difference uh, even when one part is working suboptimally. But the research that is out there shows that you can take any person, and my hippocampus, where the seat of my memory comes from, it grows about 750 new neurons every day. But most of these baby neurons never grow up and mature because we don't give them all of the optimal nutrients that it takes to grow new nerve cells. So the question is, and we're still in the midst of trying to figure this out, is how much damage is how reversible for everybody, regardless of the situation that they're dealing with. And that is something that we will hopefully in the next decade or so be able to answer those questions. But like any part of the body that we've dealt with other than the brain, we have learned through our clinical practice that there is no disease or no situation where getting in a little bit better physical shape doesn't help that condition or the person that has that condition. And so I think we will find the same thing with the brain. Obviously, if I start doing brain healthy things when I'm 50, it's going to be way easier than if I started at age 90 with full on Alzheimer's disease and try to then get that person to do this. So I'm sure a lot of you are asking, well, this must be hard to do. Um, and frankly, it is hard to get started. And especially if you have people that have significant cognitive impairment that you're starting with. You need a very dedicated spouse or daughter or son. You need to have enough people to motivate you to do these things and to coach you through it. So what we've started to do with our pilot group is we have, I give a monthly webinar where we, um, I present one of a 12-month teaching syllabus that I do uh, and tell people what's coming and share a little information with them. And then we have a small cohort of people that work on either coaching, problem solving, uh, doing whatever motivational stuff, answering questions uh, between those monthly meetings. And then we get people together um, uh, with other support features. Bredesen was fortunate enough to have a big support group of nutritionists and uh, uh, physical exercise coaches and all of these kinds of things. But we've done it with a few community volunteers and are doing acceptably well because we're making connections with people. So the next piece of stuff that I do not have organized well enough yet to do anything with it is I took all of those 80 parts of the brain on all of my 25 people in the pilot group, and I plotted them all out on a spreadsheet to see where the holes were, and then tried to compare where the similarities and differences were with these individuals. And I also met with all of these individuals 3 or 4 times during the year to go over their particular situation and see how it compared to the scenarios that they had come to this group with. And by doing that, we were able to say there was a pretty phenomenal one-to-one matching between the cognitive complaints that the individuals came to the class with and the parts of their brain that were selectively atrophied in their particular realm, their particular domain. So I'm thinking there's a whole lot more work to do here that would be incredibly valuable to the real life world's work of patients. But I think I've created a construct here that I think could move the needle quite substantially on one of the most vexing problems that we have in our society. If more people would take an interest in this, and I really feel what I'm doing is such a rudimentary look at something that we poorly understand and poorly implement. But I think it's a starting point. In my last couple of years on this topic have been the most energized I think I have been about anything in medicine, in decades, because it is a way that unites patients and their families and puts the skill set that most of us family docs have learned over the years about how to integrate all sorts of different things with people's health and try to put them in one bucket. And frankly, every part of this puzzle that I'm doing for Alzheimer's disease is also helpful for every other geriatric health complaint, you know, but I'm exaggerating a little bit, but it's good for arthritis, for obesity, for diabetes, for hypertension, for stroke, for heart attack. Uh, uh, so there is a great deal uh, of exciting work that I think we could do here. Um, so why don't I stop talking for a minute and get your response, Larry?
So, Chip, you mentioned supplements,
Hmm.
and you mentioned brain exercises.
Hmm.
Could you say a little bit more about each of those?
Sure. Um, Brain exercises is anything that follows the maxim of use it or lose it. And so it can be something as simple as a word search or a Sudoku exercise. It can be something for people that are very profoundly impaired, where we start out with just something like um, jigsaw puzzles and going from simple to more complex jigsaw puzzles. The ideal way to do it is with something that comes out of Posit Science in the Bay Area of California, where they have something called Brain HQ. And they have a lifetime membership for a very nominal amount of money that uh, will allow you to work on 25 different brain tasks having to do with word finding, with attention, with processing speeds, and things like that. And they automatically increase the complexity and the speed at which the test is so that you get better and better by practicing. The real problem with it for a patient's point of view is that they train you very, very often to by giving you harder exercises. Every click that you do that you get right leads to the next one being a little harder. So for all of the type A people in the crowd, it is really hard when you don't get everything right. You know, uh, the supplement piece is uh, that there are a lot of uh, herbal things uh, and that have been used for millennia in Chinese medicine and Ayurvedic medicine out of India. And I got a particular book of all of the memory enhancements that are used across the world uh, on 5 or 6 different continents, and which ones have the most impact on brain health. And then I found a, a national manufacturer out of North Dakota that had something called Brain Essentials, something called Pure Memory Complex, and Brain Health. There were 3 different supplements, each that were $4 or $5 a month. And so for something that maxed out at about 15 bucks a month, uh, I could give myself about 20 different ingredients in only 3 capsules a day that would maximize my brain health. Now, a lot of these have some tried uh, and reported on research in the naturopathic world. They're not things that we in conventional medicine use all that often. Um, but in any case, um, I have not been able to, and not sure that we could do anything like this to say, well, which one is best and what percentage of what you're doing is related to this part of the program or that part of the program. I've really tried to do it as a whole package, and this whole thing begs for a double-blind controlled study. And what Bredesen and his gang just released about 3 weeks ago now was their look at as a proof of concept trial on their folks, and it's in a pre-publication online journal at the moment. It hasn't yet been uh, uh, picked up by a peer-reviewed journal to see where it's going to go. But at least in this proof of concept trial, what he was able to show is that the individuals that went on this program for 9 months or more, 85% of them had significant improvement in their Alzheimer's disease MoCA scores, their ratings by their loved ones in terms of their cognitive abilities, and their volumetric MRIs with these folks with Alzheimer's disease, rather than going down by 4% a year, improved by 1%. So there was a 5% turnaround. And again, he only measured a couple of brain sections, the total gray matter and the hippocampus. He has not dug into the weeds like I did about looking at these 80 parts. So a year from when all of my enrollees got into this program, we will repeat their MRIs, and we will see what happens in these other 80 parts of the brain that are affected. So that is a work in progress, but at least the fact that Bredesen was able to do some follow-up on his cluster of people and see results that move the needle from progressive cognitive decline to more than modest. The caregivers all rated this as significant improvement in 85% of the people should be front page news as far as I'm concerned.
So Chip, when you're talking about a program, Are you seeing, so you have 25 people in your initial group, correct?
Correct.
And are you seeing them individually, and how often are you seeing them? Are you seeing them in small groups, uh, doing, a group visit intervention? I know you talked about the webinar that you offer, but how are you working with this group?
Sure. What I'm trying to do is see them all individually, quarterly, or at least semi-annually uh, in the medical office. So there is a um, um, there is a need to balance group dynamics and individual one-on-one sessions with people. And I think I would tell you that this is a work in progress. And there are, uh, like much of family medicine, uh, some other things intervene sometimes, and there can be other conditions that demand your attention in between. And so when you're seeing somebody for a cellulitis or bronchitis or something like that, you're also uh, getting another chance to touch base with them on what you're doing in the dementia program. So I'm trying to put it into the workflow of a family doc, as opposed to just uh, a specialty effort. Uh, but um, but again, does that sort of answer your question?
It does. So I'm not hearing group visits, for example. I'm hearing,
No, the only group visit is the webinar that I'm doing is a very interactive group, and that has been a 2-hour session. And, everybody says, how could you get people that are 80 years old to spend 2 hours online in a Zoom call with you? And I think I have to credit the pandemic for saying we were all, they were so grateful to see another human being that most of them didn't fall asleep, during the 2 hour session with me. But I think also, for the most part, um, at least a half an hour of that was give and take, group sharing, uh, kind of things like that. And then on top of that, one of my um, uh, uh, one of my volunteers for this ran a weekly Zoom meeting for anybody who wanted to check in on how they were doing and had any other specific questions. So I did not get involved with doing that. I got involved with just fielding the feedback that came from that. So they had a weekly small group support where there were 5 or 6 or 7 people on average of the 25 that would attend that weekly group, and it wasn't always the same 5 or 6. So the other part of the support, as I'm trying to now standardize this or operationalize it to be a little bit better, is to have my next group be a group of people that will have a medical assistant that will check in with them individually, um, uh, and as a group, uh, periodically, uh, like probably monthly, will be how the individual calls and the group visit will be, so that there can be ongoing hand-holding and coaching for all of the people that are taking on this particular labor-intensive effort.
well, that's fantastic. And out of the 25 people in this group, um, what percentage of them have had at least modest improvement?
Well, I think let me tell you about the makeup of that group a little bit. That I think there about a third of the people got into it because they had no cognitive impairment to speak of at present, but came from families that they'd watched one or both parents be institutionalized for Alzheimer's disease, so they were in it for prevention. About a third of the folks were in it because they were having more than senior moments that were driving them nuts. And they were fearful that maybe they were going down that slippery slope and they were 70 or 71 or 72, or a few of them were 65 and 68. And they were saying, where am I headed? And there were about a third that were really quite profoundly impaired. Very frankly, I have about 8 people or 9 out of these 25 that are in the first percentile for the size of their hippocampus. So there are 99% of the population their age that have more hippocampus than they do. So a very varied group, and I would say that almost everybody that had impairment has stopped losing ground or getting worse, and probably about half or more are having small victories in their everyday life. And then the question is, how do you define victories? And what am I looking for? I'm looking to hit a home run here. I'm looking for people to have across the board improvement in their volumetric MRIs, and across the board improvement in their caregivers' self-reporting on what they're noticing, and hopefully that the index members also feel like they are making progress. So we are doing a few standardized things. We're doing a MoCA, or Montreal Cognitive Assessment, on everybody that is in this group quarterly. Bredesen's work is that it takes 9 to 12 months to see improvement. It probably takes 3 to 6 months to stop losing ground, and 9 to 12 months on the program to start making a little bit of progress. And then we'll find out in year 2 whether the little bit of progress can be continued over year 2 to get to a point that it is more noticeable. Bredesen's found a few people that had significant Alzheimer's disease. They've gotten all the way better and normalized their MoCA score entirely and gone back to work. That's not exactly what I think everybody's going to experience, but at least it makes you sit up and take notice that we should be paying attention to this.
Well, Chip, I'm going to bring things to closure. I want to thank you for sharing this. And, as we were talking the other day, I think one of the core issues of our times is the great fear that people have, young and old, have of cognitive decline. And I think if family physicians are able to offer help like this, that provide solid help to help people recover, or at least stop the progression. I think that would be a service that's well appreciated by people in this country. So I want to thank you for leading the way once again, and for really taking this on quite seriously. So I very much appreciate you spending the time with us today. Thank you.
Thank you. And I think it is important that we bring hope to people that don't really seem to get it. For most of my patients in this program were told by their PCPs and their neurologists that there wasn't anything to do, and see you next year. And so you're right, people are more afraid of this diagnosis than they are of cancer or heart disease. And so it is really important that we try to provide some construct for them. Thank you, Larry.